Hello, welcome to Med One Pager. My name is Benjamin, and today I'm going to look at osteomyelitis. And in this page, I'm going to cover some recap of the basic anatomy of the bone. I'm going to talk about the types of osteomyelitis that we have, the classification that are relevant or important, or you're most likely to encounter in examinations. Then I'll have a brief overview of the investigations as well as the management. And at the end of this speech, I'm going to give you a very important notes to always consider when encountering a case of osteomyelitis, as well as some of important things when it comes to answering on examinations. So when you look at the bone, we can briefly try to recap on the anatomy of the bone, and the bone is going to basically be having the cortex of the bone, which is outside the hard part of the bone, and then we have the spongy bone inside. And around the bone, normally, we have what we call the periosteum, which is going to provide blood supply to the outer part of the bone, the outer third of the bone. And then most of the times, bones are going to have what we call a nutrient artery that enters through the nutrient foramen. And this is going to be a small hole on the bone, on the diaphysis of the bone, or the shaft of the bone, where the nutrient will perforate, enter into the bone inside to supply blood supply to the bone marrow and to the and to the spongy bone, which is called the cancellous bone. And inside the bone, we have actually a complex network. We have the lamella of the bone, we have canaliculi, we have, but then we have the Volkmann's canal and the Haversian system. And these are important, and we shall see why when it comes to understanding the pathophysiology of osteomyelitis. So the Haversian canal and Volkmann canal are just basically these sinuses within the bone where blood is going to move or the blood is going to pour. So when you look at osteomyelitis, we have some common pathogens that have been put out there or have been recognized, and mostly it's going to be Staphylococcus aureus, and this is very common, and you notice the comments on the skin. Nowadays, MRSA or methicillin resistant Staph aureus is also increasing. Then when we have sickle cell disease, Salmonella is very common, but still, even in these people, Staph aureus is common, and Salmonella is associated with avascular necrosis of, sickle cell disease is associated with avascular necrosis of the head, of the neck of the femur. Then we have diabetic food. Most of the time it's polymicrobial. In IV drug users, Pseudomonas is common. In neonates, it's Staph aureus, group Streptococcus, which they can obtain as they pass through the birth canal, and then other gram-negatives. And then we have vertebral osteomyelitis, also which is caused by Staph aureus. But sometimes we have TB of the spine, and we call that Pott's disease. So when we look at the classification of osteomyelitis, most of the times we want to classify it into three, and that is the acute osteomyelitis, that is the one that is less than 2 weeks, the subacute, which runs from 2 to 6 weeks, and when we go more than 6 weeks, we have chronic osteomyelitis, and most of the time that's when we have the terms sequestrum or sinus tract scanning in involucrum. So when we look at the pathophysiology of osteomyelitis, what's going to happen is that we are going to have entry of bacteria, and we have basically two routes. Sometimes you have the hematogenous routes where someone has a systemic infection, and then somehow the bacteria lodge to the bones, they proliferate, and they cause an inflammation there. Then we have direct inoculation, where they may be due to dramatic causes or during surgery, we introduce the organisms directly onto the bone. Then the contiguous spread, where the infection just spreads from the surrounding tissues directly into the bone. It is in adults or in diabetic foot. So when we look at osteomyelitis, it's going to affect the metaphysis a lot. And why is it going to affect the metaphysis? And this is most common in children, because if we have a systemic infection, the blood is going to flow around the body. But when it comes to the bone, we have this hairpin end arterioles. So as the nutrient artery enters and moves, gives off a branch that moves one upwards and one downwards, these are going to the epiphysis or the ends of each bone. So when they reach the metaphysis in the bones of children, they form what we call the hairpin and arterioles, and these ones form loops. So when the arterioles reach there, they actually make a 180-degree turn, and this increases greatly the pressure. It's like a kink in the system. So when the pressure goes down, we have a low flow, and then this low flow is what is going to lead to the trapping of bacteria there. So bacteria is going to stay there for a longer time, and most of the time, and when you have the growth plate there, the growth plate now acts as a kind of a barrier between the metaphysis, which is attaching to the shaft, and the epiphysis, which is up attaching to the joint. So between the metaphysis and the epiphysis, we have the vascular growth plate, and this plate acts as a barrier. It prevents the infection from spreading from the metaphysis to go up. And remember, the metaphysis is the one where most of the time we have the sluggish flow. So the growth plate has no blood supply, or it's avascular, therefore we cannot have things crossing. Then we also have a loose periosteum around the bone, and this allows pus to lift it. So when we come to the clinical features, you realize that whenever we have an infection, the infection is going to cause pus to accumulate, and when pus accumulates due to the neutrophils or inflammatory activity, then we are going to lift the periosteum off a horn. And remember, periosteum is this membrane that has the blood vessels. So early in the infection, what happens is that we have aureus is going to adhere to the bone, and then it's multiplying. When it multiplies, we're going to have inflammation. Neutrophils are going to follow the inflammation, and then pus will be formed. When pus is formed, the intramedullary pressure, that cavity inside the bone, is going to the intramedullary pressure is going to increase in that cavity, and then we end up with ischemia because of the pressure on the arterioles, those arterioles that are supplying the bone. Now, when we have ischemia, the bone is going to die. Then we have the spread of an abscess formation. So when the pus breaks the cortex, we are going to have a subperiosteal abscess, and we shall pick this up we shall pick this up always on our imaging. Then we have a sequestrum and involucrum. So when we have necrosis, the bone that is devitalized, that does not have a blood supply, so it becomes necrotic, and we give it a name sequestrum. And then the involucrum is when we have new periosteal bone that is forming around the scrotum. So this dead bone is going to act like a friend, or the body is going to try to compensate for the loss of that bone by producing new bone. And sometimes, even after we have formed the involucrum, we still have pus inside pressure, so the new bone ends up having what we call the sinus tracts, and these sinus tracts are what we see in chronic osteomyelitis. So chronic osteomyelitis is going to come when you have a persistent infection that leads to formation of sinuses, and then we have deformities coming up, and then you have recurrent flares, what you call the acute on chronic osteomyelitis. And so now let us look at the acute hematogenous osteomyelitis, and this is basically what happens mostly in the children. It's going to occur from children from years around 4 to 14 years, and it's going to affect more boys than girls because of the nature of boys. Most of the time, they're the ones that are interacting with that and things like that. And most common sites are the distal femur and the proximal tibia, and this is because of the blood supply that we talked about. In these areas, we have those hairpin arterioles that are going to have a reduced flow. So organisms are going to multiply there, but we can also have other areas like the humerus, the radius and ulna, the calcaneus being involved. And when it comes to neonate, most of the time you have a multifocal disease, and it may include the maxilla, and the spread may come from the umbilicosepsis actually. So if the cord care is not good, you may have umbilicosepsis, and we have a systemic disease resulting from that. And then the child gets a pneumonia or gastroenteritis, and the organisms find their way into the blood that goes to the bones. And when we look at the ages, there's something important about age dependence, is that children that are below 18 months, the epiphysis is not a barrier. So these children, their growth plate has not well formed, and they're still anastomosis. So we're going to have septic arthritis. And when children are greater than 18 months, the metaphysis is sealed, except where the epiphysis is intracapsular, like at the hip joint. So this means that when infection is spreading, and the child is below 18 months, the infection is going to spread to the joint, so they will have a septic arthritis. But if the child is greater than 18 months, most of the time, we do not have spread to the joint above. But it is important to note that when we have osteomyelitis, we want to always believe that we have a septic arthritis until proven otherwise. And just when you have a septic arthritis, means we're going to have pus in that joint, and it shall require one to do a drainage of that pus. Then we have acute traumatic osteomyelitis. This is going to come from open fractures, war injuries, gunshot wounds, and the risks are going to come from poor wound toilet, adequate closure of the wound, and then contaminated internal fixation or wound. Then subacute pyogenic osteomyelitis. This is when we have a disease of bacteria associated. The organism is slow, and then we end up with what we call a Brodizas abscess. And this one is going to be, because the inflammation is slow, the body is going to form that sclerotic rim to try and contain it. And that is what we call a Brodizas abscess. Then, when we look at chronic osteomyelitis, that is when we have osteomyelitis for more than 6 weeks. It is characterized by presence of sequestrum. The sequestrum acts as a foreign body, and the foreign body is going to be a place where we shall have formation of a biofilm of these organisms. Pus is going to be there, and because of this pus, we are going to have persistent sinus. So a sinus is going to be formed that will allow that pus to ooze out between the bone and the skin. Then involucrum is periosteal new bone shell that we are forming to replace the infected bone. And then the clinical features is that we have local chronic pain. Sometimes there's swelling, there's tenderness, there's deformity, exposed bone, leukinous sinus drainage, and systemically we may have minimal fever or no fever when it comes to chronic osteomyelitis, mild malaise, and sometimes the red flag is that sometimes when you have a sinus tract for long and it develops into a major Linz ulcer, which is basically squamous cell carcinoma that is developing from a non-healing wound or non-healing ulcer. So when you look at the chronic osteomyelitis, most of the time it's easier to detect compared to the acute, because the child may actually only present with features of generalized features, maybe a fever. But what is important is that whenever you have a child with a fever or history of a fever and bone pain or localized bone pain and pseudoparalysis where the child does not want to move that limb, always and always think about osteomyelitis until you prove otherwise. Then we have a classification of chronic osteomyelitis where we have types 1, where it's medullary, type 2, where it's superficial, type 3, where it's localized, type 4, where it's diffuse. And then when it comes to the host, we have type A, where we have a healthy host, type B, where we have a compromised host, and type C, where the treatment that we're going to give for the osteomyelitis is worse than the disease. Then we have complications of osteomyelitis. When it comes to the bone, we have necrosis, sequestrum, involucrum, sinus tracts forming. We can have fractures because, of course, bone is destroyed. So we can have fractures easily. We can have deformities, and then we can have growth arrest if there is involvement of the growth plate, or if there is damage to the growth plate. Then soft tissue, we can have abscess, cellulitis, septic arthritis. Systemically, we can have sepsis, amyloidosis due to chronic infection. We can have anemia, and when we have the chronic osteomyelitis, we can have recurrence. The acute and chronic, we can have a biofilm, antibiotic resistance may come, major Linz ulcer may develop, and then disabilities. Then, depending on the location, if it's an epidural abscess, we can have issues with that. For example, in the spine, we can have neural deficits, and the risk of amputation is high when it comes to diabetes. So investigations want to do ultrasound, and this is best to do early because it will show us if we have subperiosteal fluid, which will mean we have pus collecting under the periosteum. Then you can do blood cultures, which you take before the antibiotics, and 3 sets if possible. The X-ray in acute osteomyelitis may appear normal for the first 5 to 10 days, and therefore a normal X-ray does not exclude osteomyelitis. Then we can do an MRI, we can do a CRB or ESR. Those can be elevated, but they're non-specific. And then there's a golden rule that if a child has a fever and a tender bone, you want to consider that child has osteomyelitis until proven otherwise. And mostly the definitive test where we can rule out orally osteomyelitis is when we do a bone decompression or when we drill into the bone, and the presence of pus is going to confirm the diagnosis. And this seems like an overkill, but when it comes to resource limited settings, or basically anywhere whereby we have the risks of an undiagnosed osteomyelitis will always outweigh the risks of actually drilling through the bone. Then we have differential diagnosis for osteomyelitis, where we have pyomyositis, which is collection of pus in soft tissue, septic arthritis. This one is we're going to have maximum tenderness over the joints, and all movements are going to be painful. When you have sickle cell infection, most of the times may affect any sites, and there's rapid response to opioids. So whenever we have a sickler with bone pain, most of the times we defer to do the drilling, or we may have to give a try of the normal management of sickle cell crisis. Then we can consider bone sarcoma if we have a large mass with mild fever and an aggressive X-ray. So you have a hand that the X-ray looks worse than actually the symptoms. Most of the time we consider bone sarcoma. Then TB osteomyelitis, it can be chronic, it can be mild, minimal, and we have minimal periosteal reaction. Then scurvy or bleeding disorders, when you have suppressed periosteal hematoma without fever. Then rheumatic fever or viral arthritis is most of the times going to be polyarticular, so many limbs of many joints are paining. Then brucellosis, yaws, syphilis have regional patterns. So the principles of management is going to be immediate drainage of pus, and this one is very important because we saw this pus increases the intramedullary pressure, which leads to infarction or when the blood vessels are compressed. Early IV antibiotics, limb immobilization, and then supportive care. And then when it comes to antibiotic therapy, we most of the times want to do empiric treatment as we wait for cultures. Then we do the rest. So cloxacillin, ceftriaxone, clindamycin can be considered for MRSA. In sickle cell disease, we want to cover them for salmonella because it commonly causes that avascular necrosis of head of femur. Then duration, after adequate drainage, if we are able to drain also the pus, we could do for 2 to 3 weeks, but most of the time, if we start our necrosis or slow clinical improvement, we may push the treatment up to 6 weeks. The chronic osteomyelitis, the management surgery is essential, and antibiotics alone cannot cure. So surgically, you want to do adequate debridement and sequestrostomy, where you can remove the sequestrum, but you will remove the sequestrum only after the involucrum is believed to be strong enough. Then we can do cavity curated ossicularization, whereby we go to that cavity that is holding the pus and we change its shape to a more less cavity and more like a saucer, more flat. Then space management, where PMMA antibiotic beads have been put up or being thought to be important, where these beads are put in place. But of course, there is a lot of controversy when it comes to that in terms of antibiotic resistance and other things. Muscle flaps can be used, bone grafts can be used to cover up that dead space. Like a extensive chunk of tissue is debrided, can put a bone graft. Then we can stabilize that joint using external or internal fixation, because imagine this bone is weak and then it's in the long bones which are weight bearing. If we don't stabilize them, or if we don't, something in place, the patient may come back with a pathologic fracture. Then sinus tract excision, then adequate soft tissue coverage. Then antibiotics are going to be culture guided, and empirically you can give vancomycin, ceftriaxone, and modify in the long term. Sometimes if you have implants, we may require to remove the implants. If it's diabetic foot, multidisciplinary approaches involved. We need to control the sugars, then revascularization, and vertebrate disease. Most of the time we treat it conservatively unless we have neurodeficits and instability. Then important notes at the end of this video that you have to always remember in dealing with osteomyelitis, that early X-rays are normal, and do not delay treatment for osteomyelitis because the X-ray is normal. That is the decompression, and immediate decompression is going to prevent necrosis, and chronicity. And sometimes there's a saying that antibiotics antibiotics save a life while the surgery serves the bone. Yes. Then hips, osteomyelitis always assume that we have a septic arthritis. That's also true in children below 18 months. You want to always consider that they have a septic arthritis. Then Sequestrum removal must wait for strong involucrum. When you have a bodies abscess, this is subacute and it has a sclerotic rim. Then in sickle cell, think about salmonella. So we have come to the end of this feature. We have discussed a lot about sickle cell, and I hope you have enjoyed this feature. If you have, please leave a comment, please leave a like, and share this video with a friend you think might need to learn about osteomyelitis. My name is Benjamin. Till we meet again, have a nice day.